too shy if you're eating. Who's screening for brain tumor? Everybody do brain tumor? Yes, okay. Perfusion imaging, are you familiar with perfusion imaging? Yes, okay, good. Well, then, if you know everything, it's fine. Then, well, we apologize because at the beginning we thought we could conduct a workshop on laptop, on real case, but, well, it was a bit difficult to set up. Anyway, we'll go through the main imaging challenge in uro-oncology, to know the principle of this technique in advanced fMRI, and then we put in advanced fMRI perfusion imaging, but now we have to consider that perfusion imaging in uro-onco is a basic technique, even diffusion imaging. Well, you're going to review the principle and be familiar a bit with tractography and functional fMRI. Then you know the main challenge in uro-oncology is first when you see a lesion, is that a tumor? Sometimes it may mimic a tumor, inflammatory lesion, strokes, or whatever. It can really mimic tumor. When it's a tumor, what kind of tumor is that? Is that unique, multiple? Is it intra or extraaxial? Is it benign or malignant, and even what kind of subtype when it's possible. You know, now they refined quite recently the entire WHO classification of the brain tumor, and well, new names appear, some other disappeared and so on. Anyway, before surgery, when surgery is conducted, try to estimate what are some important functional area to preserve. And during the follow-up, well, we monitor brain tumor and especially gliomas in order to see when they turn from low-grade glioma to high-grade glioma. When you use chemo and radiotherapy, is it a right response or is it a pseudo response? Is that a progression or a pseudo progression? All those techniques may help you. And first, perfusion. I guess you know perfusion a bit in detail. We use T2 star dynamic series that allow you to monitor the signal time course of each voxel of the brain during the transit of a contrast media, of a bolus of gadolinium. And at the time the bolus goes through the brain, you see the signal of the brain will decrease slightly due to the susceptibility effect of the gadolinium. And in brain tumor, we're not really interested in all the temporal parameters. We're mainly interested in the brain, the blood volume. Actually, how many vessels do you have in each voxel? Do you have a value in mind of the percentage of the brain parenchyma that are represented by blood vessel? How many percent of the parenchyma it's blood vessel? Do you have an idea? No idea? Then roughly it's about 4%. 4% of the weight, or the volume, as you like, of the brain parenchyma is represented by cerebral blood volume. And it's a quite important percentage and value to have in mind. And the real value is 4 ml per 100 gram, but when you assume that 1 gram of brain parenchyma has a volume of 1 ml, it's about 4%. Then using MR is quite interesting. There are some advantages, such as there's no radiation exposure, contrary to CT. The gadolinium-based contrast media has a very poor secondary effect. And then all this allows you to repeat the examination when necessary, and you can monitor. We prefer to monitor patient with brain tumor using MR, and especially using perfusion MR. And then we can also have a long enough protocol with a long baseline, about 30-second baseline, and an overall coverage of, let's say, 90 seconds to have a real cover of the first pass of gadolinium. And the fact is that you can have a roughly good temporal resolution, about one image every second or one image every 1.5 seconds, and it gives you a nice signal temporal time course. And the main drawback is that the quantification is difficult. It's very difficult to really quantify brain perfusion using MR. It's easier using CT, because when you use CT, there's a quite direct relationship between the signal and the concentration of the contrast media. But in MR, the relationship is not linear. And then you have several mathematical operation to turn your signal curve into the concentration curve and so on. That's why we don't really need to go to real quantification using MR, but rather a semi-quantification. I'll give you explanation. Well, here just to remember that contrary to stroke, for instance, where we really have in mind what are the temporal disorder of the blood into the brain, because it takes too much time to go over the clot and so on. Here we are really interested in the density of brain vessel into the parenchyma, because it's an indicator, a biomarker of the malignancy, or it can be an indicator of malignancy. It's not very true. There are very aggressive tumor with poor vascularization, such as lymphoma, for instance, and you have some benign tumor with a high density of blood vessel, such as hemangioma, for instance. Anyhow, the idea is to estimate the cerebral blood volume. We assume that the entire signal decrease is due to the bolus of your contrast, meaning that the entire bolus of your contrast get out of your voxel. And for instance, the signal change in your voxel is entirely due to your contrast. And then we calculate the cerebral blood volume, the fraction of your blood volume into your voxel, as the integer above the curve here. Okay. Then here, for instance, it's an example. And you have here a large lesion. You see there's a contrast enhancement, and here's the CBV map, and you have a nice increase of CBV on the border, roughly where's the contrast enhancement. But you have to keep in mind that contrast enhancement is different from hypervascularization, because when you see contrast enhancement, it only means that the contrast media got out of the vessel. Normally, you know, the brain vessel, they have a blood barrier that avoid the contrast media to get out of the vessel. But in many different pathological situations, this brain-blood barrier is impaired, and then the contrast media get out, and that's why it enhances. Normally, when you don't have any lesion of the brain-blood barrier, your brain parenchyma won't enhance, contrary to your muscle, to your kidney, to your liver, or thyroid, or whatever. When you inject contrast media, the organ enhances. It works for everything except for the brain, because of this brain-blood barrier. then we assume that the entire contrast through the brain parenchyma will get in and out. The fact is it's not always true. You see here a part of your contrast media get out of the brain vessel. This is the first thing. The second thing is that you may have, for instance, hypervascularization, an increase in tumoral vessel without contrast enhancement. It's exactly this example. You see here, you have a high CBVs and an increase in density of brain vessel, of malignant vessel, and you see there's no contrast enhancement, meaning that here you have an increase of blood volumes and malignant vessel, but for the moment, there's still no impairment of the brain-blood barrier, okay? And this quite often, it's roughly is often linked. Then usually when you see contrast enhancement, it's usually a combination of brain-blood barrier disruption and sometimes increased perfusion, but it's not always the case. Then I told you, here, for instance, you see an increase in perfusion in this area. Here's the baseline in pink, in this area, in the white matter, and here's the abnormal lesion in blue. And you see, when you consider the normal value in pink, you can estimate a CBV, but in blue, you will have an increase, okay, of the signal drop due to the increased quantity of and density of blood vessel into your voxels. But the problem is that because there's some contrast enhancement, you will have this permeability effect. The bolus will get out of the vessel. And when the bolus gets out of the vessel, when you're at 1.5 Tesla, you have a T1 effect, meaning that your signal after the bolus will be higher, even on T2 star, will be higher than before during the baseline. And at 3 Tesla, there's no or very poor T1 effect. It's usually a T2 star. And at 3 Tesla, instead of having an overshoot after the bolus, you will have an undershoot, meaning that there's no T1 effect. It's a problem at 3 Tesla. It's the T1 effect is really lower, but you will have kind of a staining of the lesion by a decrease of signal due to the leakage of the contrast media out of the vessel. Then if you use a normal calculation to estimate the cerebral blood volume, you see when you have an overshoot after the baseline, an overshoot over the baseline after the bolus, you tend to underestimate the CBV. If you consider that here is the entire volume where your contrast media was diluted, you underestimate the potential curve, which should be probably rather this way. Contrary here at 3 Teslas, and instead of estimating this entire area under the curve, assuming that after the bolus it should reach the baseline level, when it's below the baseline level, you will try, actually it's going to provide you the real value should be in these areas. And there's an overestimation. Then the real life is in between. There are several techniques. And when you use CTs, and it's why you have to really pay attention with this problem of disruption of brain-blood barrier, and the real value you can extract of all those software. Here is an example given by CT. I like this example. It's very old. Of course, when you look at the image, this for you, what kind of tumor is that? No trick. Meningioma, okay? It's a large meningiomas, and in meningioma, no brain-blood barrier, okay? It's not intraaxial, it's extraaxial, and you don't have this brain-blood barrier. Then the bolus leaks normally out of the vessel. Then anyhow, when you scan the patient and you do the first calculation, you see there's a very high perfusion, then, well, it's a meningioma, no problem. But when you look at the values, it's getting weird. I told you that the cerebral blood volume is about 4–5% of the brain parenchyma volume. Here you have the value in the control area. Here you see 5 ml per 100 gram. I told you when 1 gram of the brain is roughly 1 ml, it's about 5%. When you look in the abnormal area, and especially the region of interest number 1, you see the value here, 112. 112 ml per 100 gram. It's roughly 112%. Then you have in a voxel more than 1 voxel of blood volume. This is absurd. It means it's roughly too much. Then you see the abnormal calculation of the software is only due that instead of considering this, normally it should go back to baseline. Because of the leakage, it overestimates the value of the cerebral blood volume. Then there are several methods in order to minimize or to better estimate the cerebral blood volume. There was a story with a preload. I won't detail this here, but now one of the most common approach is to do mathematical correction, and instead of considering that the curve is this way, mathematically you put the curve back at the baseline level, and then you have a better approach of the real integer under or above the curve. And here you can also try to estimate this difference between the observed curve and the theoretical curve as a baseline level to give an estimate called K2, which is K2 whatever, which is a flow of contrast media in from the vessel to the extracellular space. And then you see here, when you don't do any calculation, this is a roughly raw value. You have a certain CBV, let's say about 5, sorry. And here, when you can correct this, you see there's an increase in CBV, but you can also estimate the permeability. The idea is, okay, if you don't have these techniques or this correction technique, the idea is that you always use the same methods to monitor patients. And it really gives you a better, clearer view of the evolution of the patient under treatment. Okay, then remember that in your oncology, contrast enhancement is really different from hyperperfusion. It can be associated with hyperperfusion. It can be also associated with leakage, only increased permeability, and then it really depends on the circumstances, and the best would be to have corrected CBV value and leakage estimate. Well, you see that here, for instance, some example, glioblastoma, you have a peripheral increased perfusion on the border, again, similar in metastasis, and of course in meningioma, which are highly vascularized tumors. Okay, then roughly you may have some lesion without increase of the cerebral blood volume, such as low-grade glioma, for instance. Or you may have a roughly normal cerebral blood volume, but with permeability, meaning that all those lesions have contrast enhancement, but not necessarily associated with neoangiogenesis, such as lymphoma, pilocytic astrocytoma, radionecrosis, and of course, most of the brain lesion, the brain lesion, the non-neoplastic brain lesions, such as infectious abscess, demyelination, granuloma, and so on. And you also have lesion with a high vascularization. We say RCBV, a ratio of CBV above 2, and variable permeability. That's what we observed in malignant glioma, in metastasis, and of course meningioma, and of course this highly vascularized lesion such as hemangioblastoma. Then here's an example. It's a male, he's 18, and he has a large mass in the cerebellar hemisphere. And the right cerebellar hemisphere, you see here, you have a level, obviously it's bleeding, and you have a peripheral contrast enhancement. Okay, do you have some ideas or some hypotheses? Well, when you have such lesion, when you're 18, when you're older, you can always discuss metastasis, because metastasis gives you anything. But when you're 18, we mainly discuss two diagnoses. One large cyst with an enhancement is roughly pilocytic astrocytoma or hemangioblastoma. And then perfusion is very helpful to distinguish those two, despite those two are benign lesion, okay? Actually, surgery is quite a bit different. When you have pilocytic astrocytoma, you should remove the entire wall of the cyst, while when you have an hemangioblastoma, you can only remove the main nodule and the cyst would disappear itself. Anyway, here you see that because of the bleeding, the spectroscopy is impossible to read, but we could have a look at the perfusion. You see there's no increased perfusion, and roughly the ratio between where there's a contrast enhancement and the opposite side is roughly normal. And all this advocates for pilocytic astrocytoma. Here is the opposite example, where you have a lesion into the hemispheric, the cerebellar hemisphere. We have a nodule that enhance, a cyst which does not enhance. You see here a large cystic part, and you see in diffusion nothing much, and on perfusion you see a very hot spot, high CBV of this nodule. When you compare the area under or above the curve of this nodule with the healthy other side, or the symmetrical other side, there's a ratio of 10, meaning that the voxel in this area have a density of brain vessel 10 times higher than the healthy areas. And we saw that normal brain is roughly 4 or 5%. When you have 10 times more, it means that about half, 50%, 50% of your voxels and half of the quantity of the voxel is cerebral blood vessel. Then it's roughly an hemangio or something, okay? And here, other example, older subject with a lesion in the parietal area, which enhance roughly homogeneously, okay? You see the core of the lesion have a quite low signal on T2 or flare with peripheral edema. And when you look on diffusion image, you have a hyperintensity around, which is related to a low ADC. Okay, this is not a necrosis. Okay, then when you see parenchymal abnormality with low ADC, there are two reasons. Low ADC means that the diffusion is impaired. There are two reasons. One reason, which is quite common, it's when you have a stroke, the cell inflates because of the cytotoxic edema, then the water molecules have problems to move around these big cells, okay? And the other cause to have an impairment in moving of these water molecules, it's when there are too numerous cells, when you have hypercellularity. Okay, it's exactly when you're on a train station on a Saturday afternoon, you're going to have difficulties to move along because there's too many people. It's not necrosis. I'm not talking about necrosis. I'm only talking about the cellular content of this tissular part. Then there's a very high cellularity in this lesion. You do the perfusion and you see there's no real hyperperfusion, although there was a nice leakage, and this is typical of lymphoma. Okay, another example, 73 years old. Well, he has a left hemiparesia. You see it enhanced. Well, there's a high CBV. On the periphery, where there's an enhancement. On the tumors, also a decrease of the ADC. It's typically a glioblastoma. Okay, here is another illustration in this subject. Actually, he had an astrocytoma that turned into a grade 3 and getting malignant. And he had surgery already, and then there's a recurrence. You see there's some contrast enhancement, and then provide radiotherapy, temozolomide, chemotherapy, and we follow up. 2 months after radiotherapy, you see an increase of the contrast enhancement. There's a real increase in contrast enhancement, increase in mass effect, you see, increase in T2 hyperintensity, so peripheral edema, or, well, there's things to worry. Then we perform perfusion, and surprise, there's no increase in CBV. Then there's no increase in the density of brain vessel into the tumor. However, and it even say it's almost only leakage. K2, IK2 value is roughly that the contrast media flows out of the vessel into the extracellular space. Okay, then it really looks like a pseudo progression and or radionecrosis, and you see on the follow-up 18 months after, well, the contrast enhancement decreased, the edema decreased, and so on. Then it was a real pseudo progression or radionecrosis. Contrary, you also have pseudo-response. Pseudo-response is something we observed with bevacizumab, which has a real anti-angiogenic effect, okay? And usually after the treatment, you have a decrease in contrast enhancement, meaning there's a decrease in permeability. You also have a decrease in perfusion in neoangiogenesis. Here's the first examination. You see, you give the treatment, you have almost a disappearance of the contrast enhancement after 2 months, and after 3 months, you see, it starts again. Then it's not a real response, it's called a pseudo-response. Okay, here is one of our terrible example. We were at the beginning, it's a very old case, but at the beginning we were so surprised, we were roughly optimistic when we saw the first result. You see there's a recurrence of the lesion. Here it's enhanced. You have, well, an increase in CBV. After 3 days after the treatment, the enhancement start to decrease. The CBV is normalized, and after 2 months, well, it seems that the patient is really better, but usually this problem doesn't last very long, and you see after 6 months it restarted fully, and unfortunately it was not a real response. Then remember, there's an increase in CBV, then meaning that the ratio between the core of the hotspot on the CBV map and the reference, which has to be taken into the healthy white matter. Above 2 is roughly a high-grade glioma, metastasis, hemangioblastoma, or meningioma. And when it's below, you have numerous conditions, especially low-grade glioma, but usually there are very few enhancements, polycystic astrocytoma, lymphoma, and all this and the other non-tumoral lesions, such as MS and so on. Okay, some word about spectroscopy. Do you practice spectroscopy? Yes, you like it? Well, it's weird, I have to admit, because it's not real image. It's spectrum. We go to the basics of MR before spatial encoding, and we only grab spectrum, and spectrum from the main metabolite of the brain. Of course, we suppress water. We try, mostly water. And we try to have a good signal, and then it means that we have to be far from blood. Each time you have blood, there's a real problem with shimming, there's susceptibility artifact and so on. We have to be quite far from the skull as well, okay? And not too close to water, okay? But, well, when you have a tumor or a lesion which is located into the centrum symbiovalle, well, you can have a look. To determine whether the spectrum is good or not, you can have a look at the baseline, and we used to say that the amplitude of the baseline should be at least maximum of 1/3 of the peak of the NAA. We will talk about the peak of the NAA, but maximum 1/3. And here you see the amplitude is higher than the peak of the NAA. Then here, there's nothing you can talk about, okay? And well, in the brain, when you do spectroscopy of proton, we mostly do 2 time of echo. One long time of echo, quite easy to recognize. The baseline is usually very regular, very small, and you see nicely the main peaks arising from the baseline. And a shorter echo time at around 30 milliseconds, and usually the baseline is a bit more irregular, and you see maybe sometimes more peaks. Then here we are. What you have to keep in mind that we want, of course, in the brain you have several metabolites. We could discuss so many of them, but roughly we always talk about the same in neuro-oncology. I don't talk about infectious disease and so on, but here what we'll look at is first the peak of NAA. The peak of NAA, sorry, there's a mistake here. It's around 2. There's a little mistake, I didn't see it. The peak of NAA is around 2 ppm, which is here. And usually this peak is absolutely normal. And the fact, what is abnormal is there's a mistake on the slide. What is abnormal is when it decreases. Usually it should never decrease when compared to the level of choline. The choline is another peak which is normal. It's related to the density of cellular membrane. And the fact is that normally choline should never be above the peak of NAA. and roughly not so far above of the peak of creatine, which is just beside. Those are normal peaks, okay? Creatine as well, but we don't really care about these peaks. And myoxitol also, well, few things have been described, but it's not so useful in practice. What we are looking at in tumoral disease is roughly the increase in abnormal peak, or the appearance of abnormal peak, such as lactate at 1.3 ppm, and lipids. There are two values at 0.9 and 1.3, and all this is related to the anaerobics metabolism and cellular necrosis. We'll see this in a second. Well, first, then the choline, which is here, you see, here, should never be above the peak of the Na, okay? And roughly, the choline is at maximum 1.3, the peak of the creatine, and but roughly remember that the choline never above of the peak of the Na. Then meaning that here you have a decrease of the peak of the Na, then less neurons, and you have more cholines and more cellular membranes, possibly due to a cellular activity. Well, it's a peak you can see with short and long echo time. And we observe this abnormality mostly in tumors, but also in inflammation. When you monitor patient with tumor and you see an increase of the choline, it usually suggests that the aggressivity of the tumor increase. Lipids, then it's an abnormal content in the brain because usually they are saturated. Of course, we know there's a lot of lipids in the brain, but especially in the myelin, but normally it's saturated. And here you see abnormal lipids with two peaks at 0.9 and 1.3. Well, it's a positive, it's a positive peak. It's not a problem in itself. It usually suggests that there's a necrosis that can be related to tumor, okay, but not also necrosis related to lymphoma, to metastasis, infectious, especially atypical infection, such as tuberculosis or for instance. Also in MS, quite commonly lipids increase in MS, and you see, especially at short TE, this double peak, 1.3, 0.9. Short TE, this double peak is very suggestive of lactate. The problem at long TE is when it's associated with lactate, and because lactate have a negative peak at 1.3, it can be difficult to identify the peak of lipids at long TE. Look for lipids at short TE. Lactates, and lactates is also a marker are anaerobic metabolisms and something which is quite common in high-grade tumor, but not only. It can be also common in stroke, in infection, and so on. When you monitor glioma, then when you start to see lactate, usually it means that the hypoxic phenomenon are starting and usually roughly turn into a high-grade glioma. And as I told you, it's very important. You see, at long T, you have a negative peak. So this negative peak, it's quite tricky to identify potential lipids because they resonate at the same value around 1.3. Well, in glioma, what we observed is roughly a decrease in NAA, typical here, decrease in NAA, and an increase in choline. This is common for all glioma, low grade, high grade, and so on. When you start to have a higher grade, you will start to see more lactate, but you can also see lactate in lower grade, and especially lipids, especially when you have high-grade gliomas. Here it's a quite an interesting slide because it shows you two inner temporal infiltration. You see, they look very, very similar. We put contrast media. There's no contrast enhancement. Okay, and well, I don't give you the clinical context, but well, the image looks quite the same. The main difference was on spectroscopy. And you see here, for instance, you have a very low Na. Oops, sorry. Here you have a very low Na with a high choline. Okay. So, while here you also have a low Na, but the choline is normal, and you have some lactate. Okay. I told you that usually lactate. We rather see this in higher. Low-grade glioma turns into higher, but here you see there is no choline. Then, well, infiltrating lesion without choline is not a glioma. Okay, then here it's a typical encephalitis related to herpes. Okay, while here it was a real low-grade glioma. Okay. Well. The fact is that spectroscopy looks sometimes like, let's say, small gadget, you know. But sometimes it's really mandatory, especially for the diagnosis of what we call now diffuse midline glioma. Diffuse midline glioma, it's a new entity that arose for a few years. And it's usually infiltrating the thalami or the brainstem, and the fact that the biopsy is impossible in those areas. Then, when we are lacking the pathological diagnosis, we rely on spectroscopy, of course, on morphology and so on, but also on the spectroscopy that demonstrates the high content of choline, the lack of Na, which is really significant to determine this very highly probable neoplasias. And using the MRS, they will start using chemotherapy and so on, without any biopsy. Okay, here's a case, you see, a lesion that enhance, okay, roughly homogeneous, on diffusion, well, high signal and diffusion image, possibly so low ADC area, perfusion, no hyperperfusion, then you start to have some ideas. Well, lymphoma. Would you? Okay, and then you look at the spectroscopy. What do we see? Okay, we see some choline here, but not extremely high. Here it's the same, but choline is always higher than creatine, more than 1.3. Then there is some choline, Na, well, a slight drop. Obviously, we have lactate, and at short T, we also have lipids. And then, taken all together, it shows a real tumoral profile. Here, it's also in favor of a tumor, and the perfusion is compatible with a lymphoma. Okay. Now a few words on diffusion. You know the story of diffusion, and we say that for the tumoral purpose, we roughly look at the tissue abnormalities. We're looking at the diffusivity of extracellular water molecules, and the fact is that it allows you to estimate the cellularity of the tissular part of your tumor, and sometimes when you have some necrosis, to distinguish this necrosis from less fluid necrosis like pus, for instance. And Here are some illustration. You see, here's this large multifocal midline tumors. It was a diffuse midline glioma, actually a glioblastoma. Anyway, all those diffuse midline glioma now are considered as highly malignant, grade 3, even if they do not are enhanced. Then here you see the border of some of the lesion of a decreased ADC. Here you have your lymphoma with the tisular part with a decreased ADC. Here's the metastasis with the peripheral with a decreased ADC, again for this germinoma with a low ADC, and here low ADC lesion into the cerebellum, typical of a medulloblastoma, okay? And then it allows you to really estimate the quantity, the density of tumoral cell diffusion. It's really important. Here's another example, quite recent. You see 65 referred for initial seizure. You have a large mass of the middle frontal gyrus. You see a poor mass effect. There's very few mass effect. Contrast enhancement related to the CBV, an increased CBV, and you see all the tisular part of the lesion has a very low ADC, meaning there's a very high density of tumoral cells. And it was glioblastoma. Okay, and when you look at the necrosis, okay, this is different. And we forgot the tisular part. You're trying to estimate how fluid is this liquids. And here you see you have a ring-enhancing lesion with some liquids inside. And when you do ADC, you see the ADC of this liquid is the same as CSF, then very fluid. Okay, typical from a tumoral necrosis, and here, contrary, you have a ring-enhancing lesion, and you see that the content has a very low ADC especially when you compare to CSF. This is typical from pus, and then this is an emergency, an infectious abscess, and here is not the same emergency related to a tumor. Okay. Then that now, I mean, we have to consider that perfusion and basic diffusion are not real advanced technique, and spectroscopy shouldn't be anymore. But let's say, well, it's in this category where we still consider them. Well, tractography is quite a bit different, and let's say that it's rather more illustrative than something else. The idea is that, you know, the diffusion of the water molecules are reduced in certain direction along the neuronal fibers, and then you can estimate the main direction of the fiber tracks when you study the main direction of the water molecules. It's interesting. It may guide the surgical procedure. Actually, it was quite fashionable during the year 2000, and well, neurosurgeons now, they are more familiar with subcortical stimulation, electrical stimulation, and it would be for me or for my son or for my wife. I would prefer that they would be operated by a neurosurgeon who master subcortical stimulation rather than master tractography, because there are some weakness. Especially, you see here, the main corticospinal tract is nicely deplaced inward by this infiltrating tumor. Then, well, we see some fibers, and we feel quite confident that in this area you have fibers of the corticospinal tract. But the fact is that because of the hyperintensity in T2 here, you have a loss of this anisotropy. And then the software, when they go through hyperintensity on T2, they are totally lost, and they can't follow the fibers through this edema or the tumoral infiltration. Then here, obviously, it means that, I mean, you can't say there's no neuronal fiber. You can only say that you don't see them. But you can only say that there's no neural fiber in this region. Anyway, here just to show you that according to the technique, here, for instance, you see the arcuate tract that relies the Wernicke to the Broca area. And you see there's a large part of this tract which is displayed downward by the tumor. And when you use this good old metals with these seeds, which are roid-based, but when you use different technique, mostly based on statistics, you see that you can identify a part of the tract which is going inferiorly to the tumor, but also a part of the tract which is going superiorly to the tumor. The fact is that probably the truth is in between. Here, obviously, we miss the upper part of the tract, possibly because the tumor avoid the representation or the tractography in this area. And here, it's obviously too large for a tract because it tries to fit the probability to look like the tract rather than depicting the real tract itself. And finally, fMRI. We know, everybody knows fMRI, one of the sexiest technique that was invented, well, now more than 30 years ago. And the idea was to monitor the temporal change of oxygenation and perfusion of the brain of each voxel along time when we ask people to be at rest and sometime to move, for instance, here, to move the right hand, you see, and then the signal increase. And after the subject is at rest and after have to work again and so on. And then you can measure for each voxel, here is a black dot line for this voxel, the temporal course of the signal change along with this activation paradigm. Rest, activation, or right, and movement, rest, activation, and so on. And then, considering this paradigm, you may interfere that you have a signal change that should change with symbolized by the red line here. And for each voxel, you will test the relationship, the statistical relationship between your observed signal change to this theoretical signal change. And when this change, the relationship is above a certain threshold, you can put a red light. And finally, you superimpose your statistical mapping over the anatomy and fuse the both images. That's the way it works. The fact is that fMRI does not map the neural activity directly. It's not like, I don't know, EEG or, well, it's not electrophysiology. We only monitor change in oxygenation and perfusion a long time, and which are related to neuronal activity, but it's not direct mapping of the neural activity. And the other thing is that the spatial and the temporal resolution are using fMRI are very far from the scale of the neuron. Neurons are working at the millisecond scale. We work at the best at the second scale. Neurons, their size, they are in micron. Our size is in millimeters. And you see a factor 1,000 between the scale of functional MRI and the scale of the neuron. Then anyway, it requires a certain habit. The workflow must be mastered by the whole team. Usually you have to be really nicely helped by your technician, and you have to check for the image quality as well, to monitor the performance, and to avoid that patient moves the head a long time. And well, the idea is to really better identify, characterize the tumor location. Sometimes the sulcogeral anatomy can be changed a little bit, and it allows you to better identify the anatomy. It allows you to identify the area at risk when it's too close from the lesion. The idea is really to perform the largest resection. Now it's over the time where we used to say patients were cured with a simple biopsy. Now they try to perform a real oncologic surgery with a large removal. And of course, we hope to minimize the post-surgical morbidity. So here is some illustration. You see a tumor in the left hemisphere. He has to move the right toes. You see the activation in green in the paracentral sulcus. Gyrus. You ask him to move the right fingers. You see the activation close to the end knob on the posterior aspect of the lesion. And when he moves the lips, we are far of the lesion now, and even when we move, when we ask for the speech. Just an illustration of the reproducibility of fMRI. It's a patient, he was right-handed, and he had a tumor into the left middle cerebral gyrus, okay? And, well, it was revealed by seizure, and the patient experienced a little bit of speech arrest. It was not typical, but it seems there was some speech arrest. And then we test the patient for language, and we ask him then to perform this task in the machine, and a first time, you see, in red. And the idea is the patient is at rest, and after 30 seconds, he asks some words, for instance, glass, and he had to 2 seconds to produce in his mind, covered, he doesn't speak, a sentence with the name glass. I don't know, for instance, this glass is empty. And then he has to produce this sentence in his mind without speaking. And after 2 seconds, a bottle, he hears bottle, and then he will think that the bottle is full of water, and so on, so on, so on, during 30 seconds. And after, rest. And again, starts again with other words, okay? And then the first results were in red, you see, in red. And we were quite surprised because usually here you see there was a right hemispheric predominance. And it's very unusual. It's very unusual in right-handed subject, less than 5%. And it's very unusual even in left-handed subject, usually 10%, 10 to 15%, but not so much. Okay, and then we were quite surprised at this patient because it changed everything. You know, when the language would be supported by the left hemisphere, then the surgeon would be very reluctant to do a large resection of this lesion, while when it's mostly supported by the right hemisphere, then it allows to consider a larger resection of the tumor. And then we perform the scan one time, and because of the result that was weird, we asked the patient to come another time 3 months later, and then we observed we had this green activation. And finally, the overlap between the two examinations was displayed in yellow. And you see the overlap between the two examinations at three months difference, and then it confirms that actually the patient had a right hemispheric dominance for language. Okay, just to mention that I had my former PhD student, Duc Ha from Haiphong, and he worked roughly on a patient referred for medulloblastoma, and especially those children who experienced memory impairment after surgery, and because of his work, we understood why he experienced this memory disorder, mostly because he had a resection in the left posterior inferior part of the cerebellum, okay? And well, it's not so well known what's in the cerebellum that allows you to better to have a better memory and to be more attentive and so on. And then you perform fMRI in healthy children, and so that actually the lower and inner part of the left hemispheric cerebellar hemisphere was involved into memory. Okay, I will finish with this. Oops, voila. I will finish with this just to remember that when you're doing onco, neuro-onco, you need to have, like always for everybody, but you, more than ever, you need patient history. You need to know how he is, if he feels, if he experienced fatigues, if he has more seizure, what kind of treatment did he have. Perfusion now is really a part of our standard protocol when we follow up tumors, except meningiomas, but when we follow up tumors, intraaxial tumors such as glioma, we always perform perfusion imaging. And we perform perfusion imaging in every case of discovery of a new tumor. We also perform spectroscopy at least on the initial examination, and diffusion is also a part of the standard protocol. And okay, when the surgeon want to go into elegance area, you can talk and you can discuss fructography, functional MRI, and so on. Well, I thank you very much for your attention.